Hello from wherever you are. Thank you for tuning in and listening. So, today we're going to focus on the cardiovascular assessment, which is a really important part of identifying both acute and chronic conditions early. And remember, we're not just collecting data, we're using our clinical judgment to interpret what we're seeing and hearing and deciding what matters most for our patients. Our beautiful student learning objectives for this lecture. And we'll start with the slide, which highlights the anatomical landmarks used during the cardiovascular assessment and the 5 primary auscultation areas where heart sounds are best heard. And so although these areas are named after heart valves, the sounds are actually heard where blood flows through the valve most effectively. So before beginning the assessment, we want to position the client supine or with the head of the bed elevated at a 30 to 45 degree angle. And we want to ensure that the room is quiet and the chest is exposed appropriately while maintaining privacy. We want to warm the stethoscope to promote comfort and relaxation. And we're starting by identifying key landmarks on the chest. So locate the sternal angle, also called the angle of Lewis, which is an important reference point for counting intercostal spaces. The second intercostal space can be found just below this landmark, and it's used to identify the aortic and pulmonic areas. The slide on the left demonstrates the relationship of the heart within the thoracic cavity, and as you can see, the heart lies slightly left of the midline, and the apex of the heart typically rests at the 5th intercostal space at the left midclavicular line. And this is where the apical impulse, or point of maximal impulse, or PMI, it's usually palpated in adults. The image on the right is identifying the 5 auscultation areas, so the aortic area, which is located at the second right intercostal space at the right sternal border. And this is the best location to hear sounds associated with the aortic valve, including aortic stenosis murmurs. Then we have the pulmonic area. This is located at the second left intercostal space at the left sternal border. This is used to assess pulmonic valve sounds and splitting of S2. Then we have Erb's point, which is located at the third left intercostal space at the left sternal border. This area provides a general overview of heart sounds, and it's often where S2 is heard most clearly. We have the tricuspid area, which is located at the 4th or 5th left intercostal space along the left sternal border. And sounds from the tricuspid valve are best auscultated here. And then finally, the mitral area, or the apical area, which is located at the 5th intercostal space at the left midclavicular line. This is where the apical pulse is assessed and where S1 is usually heard the loudest. So when auscultating, we are using a systematic pattern and we're comparing sounds really carefully. The diaphragm of the stethoscope is the best for hearing high-pitched sounds such as S1, S2, and most murmurs. And the bell is used for low-pitched sounds such as S3 and S4. So while we're listening, we are assessing rate and rhythm, normal heart sounds, so the S1 and S2 sounds. We're listening for extra heart sounds, those S3 or S4, and then any murmurs, rubs, or clicks. So on this slide, we're putting things together and we're walking through blood flow through the heart and the body. So let's start with the right side of the heart, which handles deoxygenated blood. So blood returns from the body through the superior and inferior vena cava, then into the right atrium, and then it's going to follow through the tricuspid valve into the right ventricle. And from there, it goes through the pulmonary semilunar valve into the pulmonary arteries and to the lungs. And at the lungs, gas exchange is going to occur. So carbon dioxide is removed, oxygen is picked up, and now the blood becomes oxygenated. Next, the blood returns to the left side of the heart. It comes back via the pulmonary veins into the left atrium. It bypasses through the bicuspid or the mitral valve into the left ventricle, then through the aortic semilunar valve into the aorta and out to the rest of the body. So a simple way to remember this is that the right side is going to be the lungs and the left side is the body. And we're connecting this back to clinical judgment. So if the right side is going to fail, you're going to see things like systemic symptoms like edema or jugular vein distension. And if the left side fails, you'll see more pulmonary symptoms like crackles and shortness of breath. So understanding this flow is going to help us to recognize what's going wrong and where. And now we're shifting from blood to the electrical system of the heart, which is what actually controls the heartbeat. And we want to think of this as the heart's wiring system. It tells the heart when to contract. So everything starts at the SA node, which is located in the right atrium, as you can see in this picture. This is known as the pacemaker of the heart because it sets the normal rhythm, typically 60 to 100 beats per minute. And from the SA node, the electrical impulse will spread through the atria along pathways like the internodal tracts and the Bachmann's bundle, and it causes the atria to contract. And on an ECG, electrocardiogram, this corresponds to the P wave. Next, the impulse is going to reach to the AV node. This is really important because it creates a brief delay here. And that pause is going to allow the ventricles time to fill with blood before they contract. And on an ECG, this is part of the PR interval. After the AV node, the impulse travels quickly down to the bundle of His, the right and left bundle branches, and then through the Purkinje fibers, and this causes the ventricles to contract. And this is what produces the QRS complex on an ECG. And finally, the heart resets electrically, and this is our repolarization phase, which shows up as a T wave. And although as nurses we're not diagnosing cardiac conduction disorders during a routine health assessment, we're needing to understand the electrical system of the heart because it directly affects our heart rate, our rhythm, our cardiac output, and perfusion. So the heart's electrical conduction system is going to control the timing and the coordination of those atrial and ventricular contractions. And when the system functions normally, the heart beats in a regular, organized pattern that is going to allow effective blood flow to the body. And during our cardiac assessment, we're going to assess for evidence that this conduction system is functioning appropriately. So this image illustrates the cardiac cycle, which is the sequence of mechanical events that occur during one heartbeat, and it focuses on the relationship between systole, diastole, valve closure, blood flow, and the heart sounds during auscultation. So the cardiac cycle has two major phases: systole, which is when the ventricular contraction and ejection of blood occurs, and then diastole, which is ventricular relaxation and the filling. So understanding this process is important during cardiac assessment because, again, we're using these phases to interpret heart sounds, identifying abnormal findings, and we're assessing the patient's cardiac function. So now we're building on the cardiac cycle and we're connecting it to heart sounds, cardiac output, and ECG. This is where everything really starts to come together clinically. So a quick reminder, systole is when those ventricles are going to contract and eject blood, and diastole is when those ventricles are relaxing and filling. So always think when we're assessing, is the heart squeezing or is it filling when I'm listening? And in relation to heart sounds, S1 is that lub sound, which is the closure of the mitral and tricuspid valves, so the start of systole. And the S2, the dub sound, is the closure of aortic and pulmonic valves, which is the start of diastole. So when you're listening, you're really identifying where you are in the cardiac cycle. And then cardiac output. This is the amount of blood pumped by the heart per minute. The equation we use is cardiac output equals heart rate times stroke volume. And we're going to break down stroke volume into what it affects, which is preload. Preload is the volume in the ventricles before contraction, so the stretching of those ventricles. Afterload is the resistance the heart has to pump against. So we have to think about afterload as the pressure that the heart is pushing against. And then contractility, which is the strength of contraction for each time the heart is pumping. So we're asking ourselves, is the heart filling enough? Is it pumping effectively? And is it working against too much resistance? Control of heart rate. So our heart rate is controlled by our autonomic nervous system, the sympathetic and parasympathetic systems. So the sympathetic is going to increase our heart rate. It's our stress response. And then the parasympathetic is going to decrease heart rate. And this is why things like pain, anxiety, or medications can change our heart rate quickly. And then talking in relation to an ECG, we're connecting that back. Remember, we talked about the P wave, which is atrial contraction, the QRS complex, which is ventricular contraction, and the T wave we see is ventricular recovery. Finally, when rhythms are abnormal, so heart rhythms, the heart may not fill properly or may not pump effectively, which can directly impact cardiac output and perfusion. So we're always asking, is this rhythm affecting my patient's perfusion? So in addition to the normal heart sounds, those S1 and S2, nurses may occasionally hear extra heart sounds known as S3 and S4. And these sounds are often referred to as gallops because of the rhythm they create when auscultated. So these sounds are low pitched and they're best heard with the bell of the stethoscope, typically at the apex of the heart with the client in the left lateral position. So S3 heart sounds, also known as a ventricular gallop, these occur immediately after S2 during early diastole, when the ventricles are rapidly filling with blood. And this sound is caused by vibration created when blood enters a ventricle that is already volume overloaded or dilated. And an S3 sound may be normal in children, adolescents, and some young adults, but it's abnormal in adults over age 40. And in older adults, an S3 is often suggestive of heart failure, fluid volume overload, dilated cardiomyopathy, and patients with an S3 may also present with shortness of breath, aka dyspnea, peripheral edema, crackles, fatigue. So a common memory aid for the S3 gallop would be sloshing in. And this helps to remember that the sound occurs during rapid ventricular filling. So fluid overload. S4 heart sounds, this is also known as an atrial gallop, and this occurs just before S1 during late diastole. The sound is produced when the atria contract forcefully to push blood into a stiff or non-compliant ventricle. So unlike S3 and S4 is almost always considered abnormal. Some common causes include hypertension, so high blood pressure, left ventricular hypertrophy, aortic stenosis, ischemic heart disease, and this is suggestive of decreased ventricular compliance, meaning the ventricle is harder and it's less able to relax normally. So a memory aid for S4 is going to be stiff ventricle. So remember that S3 is associated with volume overload and S4 is associated with pressure overload or ventricular stiffness. So now we're moving into assessment of the neck vessels, specifically the jugular veins and carotid arteries. This is really important because it gives us information about cardiac function and also fluid status. So jugular veins or JVD assessment, let's start with talking about how they reflect right atrial pressure. So when we're assessing them, we need to position the patient at about 30 to 45 degree angle. So we also want them to turn their head slightly away from us. And we're looking for that jugular vein distension, so the swelling of the jugular vein. And again, it's not normal in most patients. It can indicate heart failure, fluid overload, right-sided cardiac issues. So we're asking ourselves, is the neck vein visibly distended when it shouldn't be? It should be flat to the neck. Next, we're assessing carotid arteries, which reflect central perfusion. So we're palpating one side at a time, never both, because we're going to avoid decreasing any cerebral blood flow if you're pressing on both at the same time. We're assessing the rate, rhythm, and the strength. And then we're auscultating for bruits using the bell of the stethoscope. So a bruit is a swishing sound that may indicate turbulent blood flow, possible atherosclerosis or narrowing of those veins or arteries. And safety-wise, this is a high-risk area, so remembering that we're not palpating both carotids at once. We're cautious in patients with known carotid disease, and if we hear a bruit, we want to palpate very gently. Now we're shifting into subjective data, which is everything the patient tells you. And this is going to be a critical step because it often gives you the first clues about cardiovascular problems, sometimes before you even assess the patient. So we're assessing risk factors. When we're collecting a history, we want to identify any risk factors for cardiovascular disease, starting with any biographical info, so age, sex. Risk increases with age and males earlier on, and then it kind of evens out. We want to talk about past medical history, so any hypertension, diabetes, previous cardiac issues, lifestyle habits like diet, exercise, smoking, alcohol. Also asking about medications. Are they taking antihypertensive medications, any anticoagulants, etc.? Family history for identifying early heart disease. And we don't want to forget that asking about assessment or asking about risk factors is where our teaching can really start. So talking about smoking cessation, blood pressure, and cholesterol control while we're getting a good history of those risk factors. Common signs and symptoms that patients might report. First is chest pain. So if a patient is talking to you and saying that they have chest pain, we want to ask more information about that as long as they are stable. We want to ask PQRST or old carts for our pain assessment. This is going to help us determine if it could be cardiac or not. Dyspnea is another big one, so any shortness of breath with activity or at rest. Then more specifically, do they have orthopnea where they can't lie flat? Do they have paroxysmal nocturnal dyspnea where they're waking up gasping? Those would be classic signs of heart failure. Other important symptoms would be cough or diaphoresis. It could indicate acute cardiac issues, fatigue, edema, fluid overload, nocturia, which is fluid shifting at night, palpitations, so possible dysrhythmias going on. So again, we're not just collecting symptoms, we're asking ourselves, what do these symptoms suggest? So for example, if they do have dyspnea and edema, we want to think more about heart failure. If they have chest pain and diaphoresis, we want to think more that they're having a heart attack. And then palpitations, we want to think, is this a rhythm issue with their cardiac status? So this slide is our roadmap for our focused cardiovascular history, and we want to think about this as a guide for what questions to ask and how to organize our thinking. So history of present illness, starting with old carts, so onset, when did it start, location, duration, character, any aggravating factors, relieving factors, timing, severity. We also want to ask about associated symptoms, fatigue, nausea, vomiting, shortness of breath, exercise intolerance. Then we want to go into looking at their past medical history for any conditions that increase cardiac risk, such as hypertension, diabetes, high cholesterol, any heart disease or murmurs, sometimes autoimmune conditions, a history of rheumatic fever. Also asking them when their last ECG or cardiac evaluation was. Family history, this is huge for cardiovascular risk. We want to ask about any early heart disease in their family, so before 55 years of age in men and before 65 in women. Any family history of hypertension, diabetes, hyperlipidemia, so this can help us identify any genetic risk factors. We also want to talk to them about their social history to uncover modifiable risk factors. Smoking is a really big one. Diet, exercise, alcohol, any drug use, especially stimulants like cocaine. Medications, we're always reviewing their medications really carefully, specifically looking at antihypertensive, diuretics, digoxin, aspirin, anticoagulants, any over-the-counter medications or supplements or herbals. And are they taking these as prescribed? So this slide is about the review of systems, basically a symptom checklist that helps us identify potential cardiovascular problems. So starting with chest pain, which is always a priority, we want to think beyond just cardiac. So if a patient says they're having pressure or squeezing, it could be angina, it could be an MI. We want to ask more about that. If they're saying that the pain is sharp or worse with breathing, it could be a problem with pleurisy of their lungs, so like fluid buildup. If it's been sudden or severe, we don't always want to just go with cardiac. It could be respiratory. It could be pneumothorax or a pulmonary embolism. Palpitations can come from many different causes. So it can come from dysrhythmias, heart failure, electrolyte imbalances, even hypoxia, or sometimes caffeine, stress, or medications. So asking yourself, is the patient stable? Are they symptomatic with it? Syncope, which is fainting, is another red flag. Some possible causes of this could be dysrhythmias, orthostatic hypotension, hypovolemia, sometimes neurologic causes like stroke or seizures, and hypoglycemia, so low blood sugar. Ask them, did they lose any consciousness during syncope? Probably. Yeah, I don't know why I said that. Okay. Fatigue. Fatigue is often overlooked because it's such a common symptom, but it can be really important. It can indicate decreased cardiac output. It can be seen in patients with heart failure, anemia, even thyroid issues, which could cause cardiac issues. And fatigue could be a main symptom of a heart attack in women because they have atypical symptoms sometimes. Dyspnea, again, shortness of breath. This is a huge cardiovascular symptom. So orthopnea, where they can't lie flat. Paroxysmal nocturnal dyspnea, which they wake up suddenly with shortness of breath. We want to ask them, how many pillows do you sleep with? Because sometimes they're, again, not able to sleep flat. Weight gain, this is a really good key clinical clue sometimes. So if they've gained 3 pounds in 24 hours, we want to think about fluid retention with potentially heart failure, maybe just fluid overload. This is something patients can monitor at home as well, but we should be asking about. Now we're moving into objective data, which is everything you observe, palpate, and auscultate during your cardiovascular assessment. Starting with inspection, we're looking at those jugular veins. We're assessing for JVD. We're also inspecting the precordium for any visible pulsations, any lifts or heaves. We want to ask ourselves, does anything look abnormal before I even touch this patient? Next is palpation, starting with the carotid arteries. Remember, one side at a time. We're assessing the rate, rhythm, and strength. And then moving on to the point of maximal impulse, so the fifth intercostal space at the midclavicular line, we're palpating the precordium, again for any heaves or thrills. So a thrill feels like a vibration. It's usually indicated, it usually indicates that there is a murmur. And then we're auscultating, we're listening to heart sounds, so those S1 and S2. We're identifying if there are any extra heart sounds, we're listening for murmurs. An advanced assessment technique would be auscultating the carotids for any bruits, which can indicate turbulent flow, so it's harder for the blood to flow up into our cerebral blood, into our brain, and so that wouldn't be great. Hepatojugular reflex. This helps assess fluid overload, right-sided heart failure. Percussion. This is less common in practice, but conceptually helps with heart borders. So not something we do. It's more of an advanced assessment. And then we're also listening for any extra sounds, any rubs, clicks, snaps, which can indicate pericarditis or valve abnormalities. So we're constantly asking ourselves during this objective data collection, is the finding normal or abnormal? What does it mean for my patient? Are they stable, unstable? And so before we even begin the cardiovascular exam, we want to make sure that we're prepared. So a good assessment is going to start with the right equipment, environment, and patient setup. So first, making sure that we have the right tools. We'll need a stethoscope with diaphragm and bell. Again, diaphragm is used for high-pitched sounds, so the S1, S2, and the bell is used for low-pitched sounds like S3, S4, and sometimes some murmurs. We want to have a watch with a second hand so that we can count heart rate and rhythm accurately, potentially a pen light or exam light to help us visualize jugular vein distension. And when we are also thinking about the patient, so we're going to be using a gown or a drape to maintain their privacy. We want to ensure that they're comfortable, especially the room temperature, because if the patient is cold, they could tense up or shiver, which is going to affect your assessment. And then proper positioning, usually supine with the head elevated at 30 to 45 degrees, especially for cardiac and jugular vein distension assessment. And always following proper hygiene. We're cleaning our hands before and after. We're cleaning our stethoscope. So this slide focuses on the neck portion of the cardiac assessment, specifically those jugular veins and carotid arteries. This is going to be an early part of your exam. Gives you insight into the cardiac function and perfusion like we talked about. We're starting with the jugular veins. Again, we're positioning the patient at 30 to 45 degrees. They're turning their head slightly away from us so we can visualize the jugular vein, and we are using lighting to observe the internal jugular vein. We're assessing for any pulsations. They should be visible but not exaggerated. And then we're also looking to see if there is distension. Next, we're moving to the carotid arteries. This is where you assess perfusion. We're inspecting. I'm looking for any visible pulsations or abnormalities. Then moving on to palpation, where we're palpating the carotid pulses one side at a time, assessing rate, rhythm, and strength. Then we can auscultate with the bell. We're listening for any bruits, so the swishing sound, and it can indicate turbulent blood flow. So arterial narrowing or atherosclerosis. And now we're moving to the precordium, which is the area over the heart. This is where we bring together inspection, palpation, and auscultation to assess the cardiac function. Starting with inspection by looking and observing for visible pulsations, lifts, or heaves. So the chest should generally look smooth without any exaggerated movement is what I mean by the heaves or the lifts. If you see strong visible movement, we want to think about cardiac enlargement or increased cardiac workload, which is abnormal. Next, we're palpating. We're locating the point of maximal impulse, and we're palpating. Normally, this is at the fifth intercostal space at the midclavicular line. Again, here we are feeling for any heaves or lifts, and we are also feeling for thrills or that vibration. Then, arguably, the most important part is auscultation. We're identifying the rate and rhythm. We're identifying heart sounds, S1 and S2. We're listening for extra sounds and listening and identifying for any murmurs. Remember, when we auscultate, we want to find those landmarks and use a systematic pattern. So we're starting with the aortic, which is the second intercostal space at the right sternal border, then moving on to pulmonic, which is the second intercostal space, left sternal border, Erb's point, which is the third intercostal space, left sternal border, and tricuspid, which is fourth to fifth intercostal space, left sternal border, and then mitral, which is fifth intercostal space, mid-clavicular line. Always following the same pattern so you don't miss anything. So this slide is where everything kind of comes together. This is the so what of your assessment. So you've gathered that subjective and objective data, so now you have to interpret it and act. So first we're analyzing any diagnostic data we've collected from our patient, looking at their lipid profile for potentially their long-term cardiovascular risk. We're also looking at cardiac enzymes potentially if they're coming in with chest pain to look for any acute injury to the heart. Also gathering an ECG if this is required, looking at their rhythm and if there is any ischemia present. Chest x-ray sometimes we grab and we can look at heart size, fluid in the lungs, echocardiogram. This is an ultrasound of the heart, which helps us look at the structure and the function of our heart. Hemodynamic monitoring, so looking at pressures and perfusion. Sometimes we grab a stress test or cardiac cath or angiography to look at coronary artery disease. Always want to ask ourselves, why are we getting this test and what is this test telling us about cardiac function or perfusion? And we're prioritizing our hypothesis of what's going on, and we want to take action. So we don't treat everything, we treat the most urgent problem first. And what could harm my patient right now? What is going to kill my patient first? For example, if the patient is having chest pain and an elevated troponin, we're going to act on that immediately. Their heart is not getting enough oxygen. They're having a heart attack. So that can lead to death, and so we want to act on that pretty quickly. Whereas if they're having an irregular heart rhythm and they're also having hypotension, we would want to prioritize that and intervene, whether that be shocking them back into normal sinus rhythm, sometimes medications. Sometimes we'll give them fluid to help with the hypotension or medications for the hypotension as well. So making sure that we're prioritizing, helping them with that irregular rhythm and hypotension. And then we're analyzing changing findings because patients are not static. We're trending their data over time. They're not always going to stay stable. So we're always monitoring their vital signs. We're reassessing their symptoms. We're documenting any changes clearly. Because sometimes a small change can signal a big deterioration in a patient. And interprofessional collaboration, you're never working alone. We're always communicating with our providers and our healthcare team. We might need to involve a rapid response team if needed, if our patient is quickly deteriorating. And based on our findings, we're developing a plan of care. So whether that be medications or continuing to monitor them or any patient education, interventions, again, are going to be based on our priority problems. And finally, we're evaluating, like when we do an intervention on a patient, did that intervention work? Is the patient improving? Are their symptoms resolving? Do we need to adjust the plan of care? So now let's talk a little bit about older adults because cardiovascular assessment can look a little different in this population. And the big idea here is that aging changes how the heart and vessels function. So we have to adjust how we interpret findings. So first, older adults have a higher risk of hypertension and heart disease, and this is due to long-term wear and tear of the cardiovascular system. They also have age-related changes, like blood vessels become stiffer as we age, and the heart becomes less responsive to stress hormones. And this means the body doesn't adapt as quickly to things like exercise or illness. Structural and functional changes, you'll also see changes like decreased cardiac reserve, so less ability to respond to stress, like I just said, and stiffer ventricles. So it can affect filling, so the diastolic dysfunction could be common in older adults. I don't know why someone keeps opening and closing their door like every 5 seconds. I'm dying. So I'm sorry about the background noise if you hear that. Anyway, they have an enlarged left atrium because valve changes, especially the mitral valve. The heart is going to become less efficient over time, and so that can change our valves of our heart. So these changes can lead to slower response to stress, increased risk for heart failure and dysrhythmias, and then subtle or atypical symptoms. So when we're assessing older adults, we want to pay close attention to heart failure, atrial fibrillation, chest pain could be atypical or absent, fatigue and dyspnea often are early symptoms of something cardiac going wrong with our patient, our older adult patient. So this slide highlights something really important. Cardiovascular disease does not affect all populations equally. And as nurses, we need to understand both the epidemiology and the underlying disparities to provide better care for our patient. So first, heart disease is the leading cause of death worldwide, and it's also the leading cause of death in most racial and ethnic groups in the United States. So the burden is not evenly distributed, so that we see higher rates of coronary artery disease in older adults, men, Native American, Alaska Native populations, and Hispanic populations. Also, African American populations, we see a higher risk for cardiovascular disease and stroke. And then in Asian American and Pacific Islander population, heart disease accounts for about 1/3 of deaths. So knowing that these differences are not just biological, they're influenced also by access to care, socioeconomic factors, health literacy, cultural beliefs and practices, and also importantly, systemic inequities. So as nurses, this means we need to be aware of increased risk in certain populations. We also need to avoid assumptions and treat each patient as an individual and provide culturally sensitive education, focusing on prevention and early detection. This slide, wow. This slide focuses more specifically on sex and gender differences in cardiovascular disease, which is really important for clinical practice. So first, males and females often present differently with heart disease. Males are more likely to have those classic chest pain symptoms, like an elephant sitting on my chest, whereas females may have atypical symptoms like nausea, fatigue, shortness of breath, back or jaw pain. And this can really lead to any missed or delayed diagnosis. So knowing that as a nurse is really important. We also have increased risk factors, so certain conditions increase cardiovascular risk in both groups, like diabetes and atrial fibrillation, which can significantly raise the risk for complications like stroke or heart disease. And then we also have underrepresentation in research, which is a major issue because females have historically been underrepresented in clinical trials, which has led to less accurate understanding of symptoms. And we also have suboptimal treatment approaches and worse outcomes in some cases. So it's really great to be a female. Mortality trends, another important point. Mortality rates in males have declined over time, and in females, they've remained relatively stable. So this highlights the ongoing gaps in recognition and treatment. Finally, cardiovascular disease risk increases with age in both males and females, but again, presentation and outcomes may still differ. So we're not relying on our classic symptoms. We want to ask ourselves, could this be cardiac? Even if it doesn't look atypical, we're always making sure to cross our T's and dot our I's. And am I considering how this patient's background may affect presentation? Ask yourself that. You don't want bias. All right, that was it for today, and we're going to practice a lot in our lab. So I'm looking forward to seeing you there. Hope you have a wonderful day.